Well, thank you everyone for joining us for the Ultrasound lecture series today. Pretty excited. We're going to have a really good conversation today. Today's conversation topic is going to be pulmonary embolism, or point of care ultrasound, or POCUS for PE. And so I've actually asked Ashish Aneja, one of our cardiologists, who's been a frequent contributor in this forum, to join me and have this conversation. So we're going to talk a little bit about an article. We're going to talk about some ultrasound findings, kind of how do we apply that with the physiology in the anatomy that we see, and then the echocardiography findings that we see. So pretty excited. Let's dive on in. Before we get started though, this is the article that things are going to be based off of. So this is called "What are the echocardiographic findings of acute right ventricular strain that suggest pulmonary embolism?" by Dr. Stephen Allerand and colleagues. It was published last year in Anesthesia Critical Care Pain Medicine. We can send that link out for you. But it's an excellent, excellent article. My props to the authors. They did a good job of reviewing all the different echo parameters that can be seen in PE, and really kind of go through one by one and say, what is it? How do you get it? What's the sensitivity, specificity? What's the literature around this? And what are some of the pitfalls that you may need to think about when you do these different studies on the echo? And so great article. We're going to talk about a couple of these things today, but specifically, let's dive into PE. And as we do that, I'm going to switch over to this screen. So point of care ultrasound for PE, we're going to talk about a few things. And I think it's helpful when we get started to think a little bit about the physiology of a pulmonary embolism. And then from there, we can build into kind of how that affects the echocardiographic findings of PE. So big picture, I'm going to do big picture, and then Ashish can kind of jump in and talk a little bit about some of the details with the physiology. But big picture, a PE is basically a thrombus that happens, right? It gets lodged in the lungs. And so the lungs are this amazing organ that we can talk to our MICU colleagues about, and they would extol all the virtues of the oxygenation, the ventilation capacity of the lungs, and various things. I see a double thumbs up from Z, so I'm on the right track there. But one of the other kind of not talked about functions of the lungs, which make it a super amazing structure, kind of where it's at, is it's a filter, right? Between all of our circulations, we have filters. So if you think about, our venous system goes through the lung, even the splanchnic system kind of goes through the liver, and it filters stuff. Because the worst thing that could happen is you have a massive thrombus in the legs that breaks off. It goes all the way through and causes a stroke, or embolizes in some other arterial system, and then you have massive organ dysfunction. So like in baseball player, you do a sacrificial bunt to get a player to move down, or around the ball diamond. The lungs are kind of that sacrificial bunting system, in a sense, to kind of protect the rest of the body in this way. And so the lungs will trap these thrombi. And if they're really, really small, probably not a big deal, at least in terms of ultimate physiology. But the bigger they get, the more circulation that they take up, the more space, surface area of available space to allow blood to transmit that they take up, and that creates some problems. And so the problems that we see, actually we'll go back here for a minute. The easy ones to think about is, okay, you have an arterial clot, right, that's blocking up some vasculature, and so you get downstream effects, right, and you'll have the pulmonary infarcts and stuff like that, that are the obvious problems of just no blood flow. If you go bigger and kind of think further downstream to the LV, you could have decreased of flow from the RV to the LV, and so you have decreased filling, and that could cause some hemodynamic collapse and things like that, that we would certainly want to know about and want to be worried about, especially as we get into the massive PEs. But what we don't oftentimes think, at least first, about is the effects upstream and what that clot does to the right heart. And that's kind of what we want to talk about today. Some of the parameters that we're going to see as we ultrasound these patients. And so if you think about it, right, we have our lungs. You have our inflow up at the top here, through the IVC, the SVC, coming into the right heart. Right heart pumps that into the pulmonary circulation. And if you were to knock out a good portion of that, right, you take away the ability for that portion of the lung to be a conduit of blood from the right heart into the left heart. And it's got oxygenation issues, it's got some LV filling issues. But what you're essentially doing is you're decreasing the surface area of available vasculature to conduit blood from the right to the left, right? And when you do that, you increase your pulmonary vascular resistance. And that's going to have some pretty significant effects, right? The analogy I always like to use is if you put a dam in a river, right? And I was going to put a picture of the Hoover Dam, but I couldn't get my computer to cooperate. But if you put a dam in a river, what happens upstream, right? You get this big lake that accumulates behind it because that flow can't go through the river like it did before, essentially. And so it's going to respond, the right heart is going to respond to this increased amount of pressure, right? This, you can't get blood through. The resistance goes up, it increases the pressure proximal. That increase in pressure is going to result in an increase in size. So that RV responds immediately by dilating, because it can't just immediately hypertrophy and respond to that increased pressure. It's going to have to just accommodate that by getting bigger, right? And that's kind of the big picture effects of what's going on inside the right heart. And from there, we're going to see some echo effects and some of the things that we're going to talk about today, come into play. But before we move on to that, I just want to invite Ashish into this part of the conversation and say, all right, so we looked at from a 30,000 foot perspective about the physiology, but let's dive in a little bit. Ashish, what are the effects that this level of increased pressure, and we're going to assume a submassive to a massive PE for the conversation today, but what are the effects of this increased pressure and even the size, the dilation of the RV? What effects does that have on the right heart itself in terms of its ability to function and perform its job?
So I think you've done a great job of covering. Thanks for the introduction. So essentially what happens in the acute phase is that the right ventricle, like you mentioned, has no place to hypertrophy, right? So when you have an acute pressure overload situation, the right ventricular pressure is simply not capable of going above a certain level, right? So, and that's why we're going to talk about this in future slides, is that the PA pressure tends to remain below the severe level because the right ventricle is simply not able to cope with numbers in the 60s or 70s systolic, okay? The ventricle dilates, it increases oxygen demand on the right ventricle. There's development of right ventricular ischemia. There's development of right ventricular, there's a rounding off of the right ventricle, which creates further inefficiency of contractility. And again, in the acute PE situation, you have an obstruction, especially with a large PE, you have an obstruction of the proximal circuit of the pulmonary circulation. And what happens is that when the right ventricle contracts, it actually sends down a pressure wave that goes forward into the pulmonary artery. And then the pressure wave reflects back from the pulmonary artery back to the right ventricle. And it shows up in the form of the pulmonary artery ejection. The more proximal the obstruction, the more the more rapid the rise in pressure in the right ventricle is. And you will see, again, in the acute phase that the pressure simply just doesn't go above a certain level. In patients that have chronic volume and pressure overload, potentially because of lung disease or disease of the pulmonary vasculature, the right ventricle now has time to hypertrophy. And the hypertrophy allows, by the law of Laplace, for the pressure to actually go up significantly more than your initial pressure of, say, 50 or 40 or 60 millimeters of mercury. I'm talking about peak PA pressure. And the shape of the right ventricle also adapts. It becomes differently adapted. You don't get that, right ventricular ischemia because the right coronary flow goes up. The marginal branches of the right coronary artery actually increase flow to the free wall of the right ventricle. So it's less likely the right ventricle will dilate in the face of an acute pressure overload, especially if it is hypertrophy, because it has significantly larger radius, but at the same time the wall thickness is increased, and it's much less likely to actually become more dilated. So I don't know if that answered your question, but it was a long circuitous answer.
No, that's great. I mean, I think that's really helpful to think about it in terms of, the acute versus chronic. Like the right heart has its ability to lift or to function to a maximum degree in the acute phase. And we're going to see this come into play, in later in the talk today, as we talk about kind of some of the Doppler parameters, but knowing that like it can only do so much, like it can only up its performance so much in the acute phase is really going to be helpful kind of in learning that distinction. So with that said, we know, okay, so we put a a thrombus in there, we get an increased pulmonary vascular resistance. We have an increased pressure that's seen in the right heart. The right heart's going to respond to that acute increase in pressure by increasing its size, because it can't increase its hypertrophy just in the acute phase. So let's look a little bit at the ultrasound side of things, right? Let's look at some parameters echocardiographically of right heart strain that we're going to see in patients with PE, right? So the first big one, and I got 3 of them here to show everybody. And Ashish, feel free to jump in if there's something that you want to add kind of as we talk through this section here. But this is kind of lay the foundation. This may be a review for a lot of people. But this hopefully will kind of lay the foundation, kind of see the 2D, the planimetry view of the echo, so that we can kind of understand better the physiology when we start throwing Doppler on top of that. So, but the first parameter of right heart strain is basically going to be an increase in the RV size. I mean, we talked about it already. The RV is going to respond by increasing its size. And so normally the RV is going to be a lot smaller than the LV, right? And normal ratio is going to be about 2/3, the RV is going to be about 2/3 the size of the LV. So 0.6 to 1 in a ratio. But when you put that increased pressure that it has to respond to, it's going to dilate, it's going to become bigger. And that ratio is going to become, closer to 1 to 1, right? And so you can do the measurements. You have to measure it in diastole, right? When the chambers are as big as they can get, and you can just measure the endocardial to endocardial border on both of those, and kind of throw that into a calculator, or even just look at it, and is it the same size or bigger, to see if this is an indicate or going what's going on. The problem is it's not seen in all patients with PE. I mean, if you're talking about subsegmental PEs or even some segmental PEs, there may not be enough of a increase in the pulmonary vascular resistance to really, cause this degree of RV response, right? So the sensitivity is actually about a coin flip, right? If you see it, great. If you don't see it, you can't rule out a PE based on this finding alone, right? So it's about 50% sensitive. When you see it, right, the specificity is not bad. And I think some of that probably has to do, I didn't dive into all the papers that looked into it, but it probably has to do with it's kind of a higher pretest probability patient. If we have someone who comes into the ED with pleuritic chest pain, tachycardia, and hypoxia, and we do this, right, and we see an increased RV size, that's a high pre-risk probability patient. And so that's going to really give us some information. Whereas if I just kind of go out and scan, 100 people here in town, it may not perform quite as well. And the reason for that is the increased RV size can be seen in a number of things, PE among them, right? It's one of the things that increases that RV pressure. But things like long-standing COPD, right? Pulmonary hypertension, sleep apnea, I said hypotension, pulmonary hypertension, right? Sleep apnea, things that cause pulmonary hypertension, or even RV infarcts, right? Are all things that are going to impair the RV's ability to either, respond. And so it's going to, dilate or increase the pulmonary pressures, forcing the RV to dilate a little bit. So that's number one. Number two, that kind of goes along with it, is septal flattening, right? So what you'll see here is as that RV dilates, right, it's responding to an increased pressure. So the pressures inside the RV are going to be higher than they were if you didn't have that PE. And if you think about the pericardium, kind of like you think about the cranium, like you can't hit your head, bleed into your head, and not herniate something and not have a big bleed without risking herniation, because that cranium is a very closed box, right? It's something that's going to prevent basically a lot of size increase. And the pericardium to some degree does the same thing. It's going to maintain a certain amount of size. And so you have to then kind of equilibrate your pressures, accordingly. So as the RV sees increased pressure, and then obviously if you have an obstruction to flow, you can't get things through the lungs into the LV, you may have a decreased LV filling. So the LV is going to see a slightly lower pressure potentially, or filling pressure. And so what's going to happen is that pressure differential is going to flatten out that septum, which is normally higher pressure in the LV, causing it to be bowed into the RV. Now we're starting to see higher pressures in the RV. That's going to, flatten that thing towards the LV. As we start increasing those RV pressures there. And the third item that we'll see, and this is oftentimes talked about in a lot of point of care settings in the textbooks and things like that, is this idea of McConnell's sign. And I know years ago when I trained, this was thought to be very specific for PE. And if you look at the numbers that we posed here, the specificity is, decently good. If you see it, then you should be kind of concerned about a PE. That being said, there's been some other literature that's come out that's basically said, well, maybe it's not quite as specific as we think. And so the range of specificity kind of goes from the low mid 90s up to high 90s, but the sensitivity of this thing is poor, right? You can't not see a PE, or you can't say I don't see a McConnell sign, so it must not be a PE. Like there's a whole bunch of PEs that don't come to this threshold. But essentially what a McConnell sign is, and we see it here, is kind of that stunning of the RV free wall, right? So you don't see a lot of movement there, or they call it hypokinesis of that RV free wall. And you can kind of imagine and see a little bit in the shadow. I know it's not the best example, but right where that arrow tip is you can see some movement of the RV apex, right? So it's preservation of the RV apical movement with hypokinesis of the RV free wall, right? And this is McConnell sign, and there's multiple mechanisms that have been suggested as to the cause. And maybe Ashish, you can kind of weigh in kind of where you land a little bit on this one. But there's multiple mechanisms. One is that the RV apex is like just physically tethered to the LV. And so what you're seeing is when that LV is still contracting, it's going to pull that RV apex with it. But the rest of the free wall, since it's not tethered, is going to be has nothing to kind of make it move, right? So there's that tethering mechanism. The other mechanism, the wall stress mechanism, kind of goes along with the ischemia. It's kind of two steps in the ladder. And they say, well, maybe it's because you have this increased RV size, right? We're having increased tension on the wall. Remember, we talk about, I believe it's Laplace's law, like when the aorta, right? You have the aorta dilation, right? It gets to a certain point where it's so big that the stress on the wall is the stress on the wall kind of overcomes the ability of the wall hold together, and it ruptures, and you have your AAA rupture, right? Same thing here, right? You have this increased wall stress, like as it dilates, it puts tension on that wall. And that could be a portion of it. Or what could happen is maybe that's causing some downstream ischemia, like some subendocardial ischemia, where you just have decreased ability to perfuse the small capillaries in the RV wall. And we're seeing kind of ischemia. So like almost like a regional wall motion abnormality, the RV, just kind of with that ischemia that's happening. So all these are plausible theories. I'm not entirely sure, based on my reading, if we know exactly which one's the cause, or maybe it's all of them that's causing it. But the issue here is that it's kind of low sensitivity, okay specificity. I accept that. But the pitfall is that you can also see this in other things like an RV infarct. So if you have a primary infarct, maybe this is kind of what's going on as opposed to your PE. So there's some things just to kind of keep in mind as we think about this third thing that we see on 2D, when you have a PE. So any thoughts or comments there, Ashish, before we kind of move on to the next thing?
No, I think you covered it really well. What I would add to that is that the McConnell sign, would probably not be best assessed in the subcostal view, because that's really, only a part of the right ventricular free wall. You're looking at the inferior wall of the right ventricle in the subcostal view. The right ventricular free wall is best seen in the apical four-chamber view. So, but what you're showing here seems to be a pretty good example. Quick mention about how the right ventricular size is assessed in the apical views. There's actually multiple views on which you start assessing right ventricular size. The first one is the parasternal log axis view, which is one of the standard echo views. And you start getting a sense of whether the RV is dilated right in the first image that we acquire. The second was the parasternal short axis view, which is really focused upon assessing the aortic valve and looking for tricuspid regurgitation jets. In that view, you can assess the size of the right ventricular outflow tract and also the free right ventricular size and how the right ventricle contracts. You showed the short axis view more the mid left ventricular level, in which you have the septal flattening and the bulging of the septum into the left ventricle if there's both pressure and volume overload. Even that view is pretty helpful as far as the assessment of RV size is concerned. The apical view can be tricky in terms of assessing right ventricular size. The traditional four-chamber view that is acquired at the apex can sometimes underestimate right ventricular size. And what the societies tell us to do is to actually perform what's called a right ventricular focused view. And the right ventricular focus view requires that the transducer be moved a little bit medially and be rocked a little bit. Talk about it. In theory, I think it has to be done. Would be much nicer if you're at a patient's bedside and actually demonstrate the focused right ventricular view, which brings out the correct size of the right ventricle. And that's the view in which we recommend measuring the maximal extent of the right ventricular base. So those are some of the additional issues, but I think you covered it really, really well.
Cool, thank you. So with this kind of foundation in mind, I mean, we talked a little bit about the physiology of kind of what's going on. We talked a little bit about the 2D findings of what's going on. I want to introduce this idea and then really kind of let Ashish go and kind of talk about it, about another sign that you'll see in this paper that that we introduced at the beginning, called the 60-60 sign, right? And kind of how this can be used in the ED to kind of understand that physiology of what's going on with the PE, and then assess our patients to help us kind of move the diagnostic ball forward, right? So with that being said, I'm going to show just some pictures of a case that we had not too terribly long ago that kind of are getting at that 60-60 sign. So Ashish, here's this patient, I think had a saddle embolus, if I remember correctly. But basically showing the apical forechamber. And so there may be a little bit of foreshortening on that RV, a little bit, but you can definitely see that it looks a little bit big compared to what it ought to be on the apical fore. And then if you go to the short axis, the parasternal short axis, we can see some RV flattening. So 2 of the 3 different signs that we talked about a little before. So we definitely know that something's going on. And, this one, I kind of knew what was going on before I scanned the patient. But if you were scanning this patient de novo and you had a right story, like, something's not quite right here, especially if their previous echo was normal, to kind of get the ball rolling. But then I did these measurements, right? And so this is going to be what we're going to talk about. How do we add Doppler to this assessment to really start seeing this physiology play out right in front of our eyes, not just have it be some theoretical thing that we just, we understand is going on, but don't actually see. So measured the tricuspid regurg jet velocity and measured the pulmonary artery outflow, essentially, the jet, but kind of the acceleration time there. So with that being said, Ashish, there's this thing called the 60-60 sign. I know you know it because you obviously know a whole lot more than me about cardiac echo. But tell us a little bit about the 60-60 sign. I guess first just to define it simply, and then we'll break it down piece by piece, like tricuspid valve, what's it doing? Why is it doing it? Pulmonary outflow tract, what's it doing and why is it doing it?
Yeah, absolutely. So let me define the 60-60 sign. The 60-60 sign means that in the setting of an acute pulmonary embolism, the pulmonary artery acceleration time is less than milliseconds, and the peak PA systolic pressure in the absence of previous pulmonary hypertension is less than 60 millimeters of mercury. Okay, so the PA systolic pressure, is measured by assessing the gradient between the right ventricle and the right atrium by looking at the tricuspid regurgitation jet velocity. So you have a focused beam going across the right ventricle that's being shown on the left side of the slide here. And you have the parabolic contour of the tricuspid regurgitation jet that's shown right below the cartoon of the heart. And essentially what you're doing is you're using the Doppler principle to calculate the gradient between the 2 chambers. The Doppler principle by the Bernoulli equation states that the gradient between 2 chambers is 4 times the square of the velocity. So if your velocity is say 4 meters per second, that's the velocity difference between the right atrium and the right ventricle. The gradient there is going to be 4 times 4, which is 16, times 4, which is 64. So your PA pressure is now going to be 64 plus the right atrial pressure. So that's the difference between the 2 chambers, between the right ventricle and the right atrium. And then you add the central venous pressure to that, because the atrial pressure is really, the pressure in the atrium is preventing the PA pressure to go up to the extent that it would. So in other words, the right ventricular systolic pressure is the same as the PA systolic pressure by a difference of except for the difference of the right atrial pressure. So if your inferior vena cava and you have a high CVP, then your PS systolic pressure is going to be the gradient between the right ventricle and the right atrium plus the right atrial pressure. So that's how we calculate it. Now, that's in the acute PE, since the right ventricular wall is not thick enough to mount the kind of pressures that we talked about, the total pressure between the pressure difference between the two chambers is typically to the order of, what we see typically in a large PE is in the 40s, 50s, okay? And then you add your CVP to that, which may be 5, 7, sometimes it's even low. So your total net pressure is less than 60. When it comes to the pulmonary artery acceleration time, it's done by a technique called pulse wave Doppler. I'm assuming most of you in the audience are familiar with that. So the right side of your slide is showing you a short axis view at the parasternum, and you're seeing the Doppler beam actually pointing across the pulmonary valve, and you place the sample volume of the pulse wave Doppler just above the pulmonary valve in the right ventricular outflow tract. And what you get is this waveform, which looks like, in normal individuals, slopes up gradually, okay? And then it not gradually, slopes up somewhat sharply, but then it descends kind of gradually. In patients with pulmonary hypertension of any etiology, there's a sharp increase in the pressure. So that when the right ventricular ejection occurs, there's a rapid rise in the pressure waveform, and then you see a reflection wave. Okay, so we're just going to talk about the initial limb of the pulmonary artery pulse wave Doppler waveform. So in patients with pulmonary embolism, since the obstruction, significant pulmonary embolism, since the obstruction is very proximal, there's a very rapid rise in right ventricular ejection dynamics, and it leads to a very rapid equalization of pressure between the right ventricle and the pulmonary artery. And therefore, it leads to a PA acceleration time from beginning to end of less than 60 milliseconds. This is a very, very helpful sign in clinical practice. And when we see this, we find it to be quite helpful. The other sign that Matt may talk about in subsequent slides may be the notching, and I'm going to leave that up to him, and then we can elaborate further upon why the notching occurs in the pulmonary artery waveform and why the timing of the pulmonary artery notch matters. Hopefully that answers the question.
No, great. Thank you, Ashish. I think that's super helpful in kind of understanding it. And so just to recap from kind of what you talked, we have these two things, right? We have the pulmonary artery acceleration time that we measured in the pulmonary outflow tract there. And we can see that on the right-hand side in this in vivo image, right? And then you have that tricuspid regurg jet that's going to be a reflection of the pressure that is being seen in the RV, in the PA pulmonary artery that we're measuring here. And so for this patient, Ashish, we can probably critique this one a little bit, but I think it brings up some interesting questions that I have about this. They definitely fit it by the pulmonary acceleration time parameter, right? We have a shortened PAAT, but we have basically a jet that is going to measure without adding the right atrial pressure. We're looking at about 68, I think, millimeters of mercury is what it says here. So that's already a little high. It kind of broke that less than 60 rule for our pressure gradient, pulmonary artery pressure. And then we add on our IVC, and it's going to be anywhere from 3 to 10 millimeters of mercury higher than that. So I guess the question I have is, I guess I'll just throw these out there, is what are some of the pitfalls that we may run into as we're trying this technique, on patients that we need to keep in mind as we're doing it? We'll start broad, and then I got some other specific questions that we can kind of drill down in there for this one. Yeah,
so I think the key here is that tricuspid regurgitation jets can be fickle. Okay, so one can never be certain as to the location where you would find the highest velocity, right? So you have to have multiple views in which you look for TR velocities. The first one that we perform is the parasternal short axis view, and I wish I had a slide to show you what it looks like. But think about the previous slide that Matt showed, in the parasternal short axis view, where you actually have your beam directed towards the pulmonary valve. So can you go back to your previous slide quickly?
Yeah.
So see the right-hand side of your, on your screen, you see the Doppler beam going down the pulmonary valve. What you would now, and to the left side of the screen, adjacent to the aortic valve, is the tricuspid valve. Now what you do is, instead of using the pulse wave Doppler, you pick up continuous wave Doppler and you point it down the tricuspid valve. And that's your first view in which you start picking up the tricuspid velocity. And oftentimes that is where you find the highest velocity, okay? The image on the left side of your screen is showing you, tricuspid velocity being measured across the right ventricle in your traditional four-chamber view. And they've done a smart thing by showing that the right ventricle is dilated and the beam is now the continuous wave beam, which is going across the tricuspid valve. The four-chamber view sometimes yields the highest number. But the last view in which we look for the highest tricuspid velocity is the subcostal view. In many instances, the tricuspid velocity is not evident to its fullest extent in those two standard views that I just talked to you about. So the American Society of Echo recommends that you also measure the tricuspid velocity in the subcostal view, especially when you have an eccentric jet that's directed towards the interatrial septum. So if you're doing color Doppler, you will notice the direction of the jet, and if it's lined sort of eccentrically towards the interatrial septum, you'll be able to pick up the highest TR velocity in that view. So despite doing all of these different measurements, you may not get a good TR signal. And this is where the role of left ventricular contrast or ultrasound enhancing agents comes in. These agents can enhance the contour and the shape of the tricuspid regurgitation jet and other significant Doppler mechanism sort of waveforms in the heart. So if we've given contrast, the sonographers will always go and look for tricuspid regurgitation with the use of contrast, and that will bring out the velocity in its best form and its best fidelity in many cases where it is not visible to Doppler in an unaided situation. So and despite all of that, the sensitivity and specificity of, or I should say, the correlation statistic between PA pressures measured by invasive left heart and right heart catheterization and by echo are off often about 30-40% of the time. So even in the best of hands, you may not find the best correlation. There's both underestimation and overestimation. Some of it is explained by the fact that you're not doing those measurements simultaneously. If you're doing an echo today and you're doing the cath tomorrow and the patient's lying flat and patient's sedated during the cath or ventilated, a lot of different things can occur between when the echo was done and when the invasive right heart catheterization was done, and that could explain some of those differences. But many times it's because echo is not able to pick up the PR gradient properly. Hopefully that answers that question.
Sure. The other questions I have is, so if someone who's previously healthy has a PE, right? This works. In fact, I haven't talked about the evidence for this, but the sensitivity specificity is going to be somewhere in the neighborhood of about, for submassive and massive PEs, about 51% sensitive, 96% specific, which is actually pretty good on the specificity side. And then for the segmental ones, sensitivity drops down to kind of something really, really meaningless. But specificity is still retained at about 94%. So for someone like who's got a normal echo beforehand, obviously it's going to work really pretty good. What about people with pre-existing pulmonary hypertension? Kind of is that just going to increase our TR jet velocity? Kind of what affects, or does it kind of just become a meaningless test, if you have known pulmonary hypertension?
It's not a meaningless test. So, as you can imagine, if you know your patient's baseline pulmonary arterial pressure, say it's 45, and now you have an acute pulmonary embolism, and now it's 65. I think you know that something acute has occurred, right? You can always, and you have the acceleration time comparisons also that can be made. You may have an acceleration time that's 75 milliseconds, which is still pretty rapid. Anything less than 120 milliseconds is considered abnormal and too rapid for the acceleration time. And if there's a significant change in that, then one could argue that there's something acute over chronic going on. So you can certainly make that case. It certainly becomes more difficult to call an acute PE in patients that have chronic pulmonary hypertension. Definitely more challenging in patients that have, say COPD or left heart failure, which leads to pulmonary hypertension most of the time. The most common cause of pulmonary hypertension, at least in the patients that we see, is left-sided heart failure. So in those cases, diagnosing an acute PE can be tricky, but you go back and compare. When you go back and compare the right ventricular size and function, we often find that there's been worsening in terms of the size and function, and that sometimes is a clue towards the diagnosis of acute PE.
The other question that came up in the chat here from the MICU is in regards to intubation, right? So how does the fact that someone may be intubated and now on positive pressure ventilation, we decrease that ability for the thoracic pump to kind of to work, right? And the effects that it has on the right atrial pressure. How does intubation affect our ability to perform this test?
So intubation in terms of how the echo images are acquired, or how to interpret the data?
Does the intubation have an effect on the physiologic findings that we're seeing here?
Absolutely. So what it's going to impact predominantly is the vena cava size, right? So when you have positive pressure ventilation, the inferior vena cava becomes large in size because there's an increase in the intrathoracic pressure, right? So the increase in intrathoracic pressure prevents the inferior vena cava from filling in the way it would normally do with respiration, right? So you have the opposite. So in patients with the normal CVP, you can have a dilated IVC. And the one time that the IVC size is useful in patients who are mechanically ventilated is if the inferior vena cava size is small, okay? So if the IVC is small in a patient that's ventilated, you definitely know for certain that the CVP is low, okay? If the inferior vena cava is dilated, then all bets are off, and you don't really know what the CVP is. But it should not significantly affect the tricuspid regurgitation velocity. The one thing we ought to remember is that in patients who are very, very sick acutely, there's a significant shift in the right ventricular stroke volume with every beat, right? So in patients that have a pulsus paradoxus because of significant pulmonary dysfunction, you can sometimes see a marked variation in the tricuspid regurgitation jet velocity as a function of breathing, right? So in patients who have really significant pulmonary hypertension because of lung disease, with inspiration, the right side fills, and you'll see a much higher TR velocity. With expiration, the right side kind of empties, and you'll see a lower tricuspid regurgitation velocity. And this difference becomes very marked in significant COPD or asthma exacerbations. We don't see that much of a variation in the TR velocity in patients with pulmonary embolism because it's kind of a fixed obstruction. So you will not see a significant fluctuation in cardiac output, but the cardiac output fluctuation is much more pronounced in patients with bad lung disease, especially in those people that have the more compliant pulmonic arterial circulation.
Great, thank you. So I guess we'll kind of wrap this section up, but I wanted to talk a little about one thing. Ashish, you mentioned a little bit about this pulmonary notching, and I did want to kind of hit on that if we had time. So we see a little bit of that here on the right side of the image, but one of the other things that can be seen in patients with PE is this notching of the pulmonary artery Doppler packet. So can you tell us a little bit about this pulmonary notching, kind of what's causing it and what are we looking for here?
Yeah, so what happens is in normal individual, I wish we had an image of a normal pulmonary artery arterial pulse wave Doppler. What you would see is the descending limb, which is being measured for time here, as going down much more gradually, okay? So you would see an acceleration time usually exceeding 120 milliseconds. So you go all the way to the baseline and you measure the tip of when the velocity actually peaks, okay? And that time is considerably longer because the right ventricular pressure is rising gradually, okay? And you're talking about a very compliant pulmonary circulation. And typically, the right ventricular ejection is delayed compared to the left ventricular ejection, as everyone knows. And that's why you have the left-sided heart sounds preceding the right-sided heart sounds. In patients with marked pulmonary hypertension, there's a much more rapid peak of pulmonary arterial pressure because the pulmonary circulation is non-compliant. And you will see that there's a temporary cessation of flow from the right ventricle to the PA when the pressures equalize, and the wave that is a propagation that goes forward from the right ventricle to the PA is already reflecting back because either the circulation is non-compliant or there's an obstruction to the circulation, as occurs in the case of a PE. So the timing of the notch is determined by the location and the severity of non-compliance in the pulmonary arterial tree. So if the location of the obstruction is quite proximal, as would occur in the main PA, or the proximal main segments of the pulmonary, the right and left pulmonary arteries, the reflection wave occurs quite rapidly. So you will see a notch that is almost like a spike and dome. If you read that paper, it's very well described. So the spike has this short duration, and then the dome has a much longer duration because the obstruction occurs during the earlier part of the cardiac cycle. In patients that have a more chronic pulmonary hypertension type situation, the acceleration time could still be pretty short, but the downslope of the spike is a little bit more delayed. So you'll have the flying W sign or the spike and dome. The spike is not quite as sharp. Okay, so the peaking, or the point at which the waveform reflects back from the pulmonary circulation back towards the right ventricle is delayed in patients that have chronic PH, and therefore you will see a more gradual decline of the spike, if you may. So that's sort of the difference. So in acute PE, a narrow spike is actually fairly predictive of, or I should say, is quite sensitive and specific for a significant size pulmonary embolism.
Right. So the last thing I want to do in the time that we have remaining here, and I know we're kind of getting to the end of our hour, is kind of taking all this back to the bedside, right? So I think all this is fun to talk about from an academic standpoint and a theoretical standpoint, but if it really has no bedside significance, it really is kind of just more that it's more academic than anything. And I think this is highly clinical and highly helpful. So let's take it back to the bedside, right? You're the clinician at the bedside, whether you're in the ED or the critical care environment. You have a patient that's either a known or an unknown PE. How do we then kind of interpret this data that we're gleaning in front of us? And what can we say? Let's presume, for the sake of the example, that we're seeing an undifferentiated patient. We don't know if it's a PE. We're assessing the patient. We start seeing this. Kind of how should we start using this in our thought process, in our workflow for PE? So Ashish, go ahead and just kind of give us your thoughts as a cardiologist. Maybe we can, I can chime in as an ED physician as well.
I'll let you go first on this one, and then maybe I can add something to that.
Sounds good. So from my perspective, I don't think I ever have used the echo to make the diagnosis of a PE and stopped there, right? So I think it's always suggested the diagnosis of the PE, but most of the time for me, I think it's really, I'm using it to quantify the severity of the PE, right? If I'm clinically worried, my workflow kind of goes through, either the PERC score or a D dimer if their pretest probability is low, or a CTPE to evaluate, and then I kind of have my answer from there. But then from there, there's a whole spectrum of, what should I do with this patient? I mean, can I safely send the patient home on anticoagulants, or do I need to admit them for some reason? Or if they're crumping, do I really need to do something for them right now? And so I've looked at the echo, and maybe I could do some more with it, but I've looked at the echo as kind of a prognosticator once I know the diagnosis. And so I think for me, this is just more data to suggest the severity of the PE, kind of like TAPSE, kind of you give that number and it's like above and below a certain value, the mortality kind of goes up or goes down. For me, this is kind of an understanding the physiology, saying, okay, I have a large you know, large vascular area occlusion, and I'm seeing it show up physiologically on these parameters. So I should probably, you know, either be ready with therapy, or kind of triage them to a higher level of admitted care. But I don't know, like, should I be thinking about it differently? Should I be using it differently? Kind of how would you as a cardiologist kind of interpret this data?
So I think so what you just summarized is actually perfect. This is the way echo is to be utilized. We always teach our trainees that echo is not used for the diagnosis of PE. Can only be useful for prognosis, which is what you mentioned just a couple of moments ago. So I 100% agree with your take on what the role of echo is in these patients. You obviously have to have a specific imaging test like a CTPE or a pulmonary angiogram to make the definitive diagnosis. And the role of echo is really in the prognosis, frankly. And the massive or submassive PEs is where echo can be extremely helpful. But you have to make your decisions, and you'll often find that a few days after thrombolysis or catheter-based therapy, the ventricular function actually goes back. The right ventricular function goes back to normal. So the wonderful thing about the right ventricle is that, unlike the LV, since it's not used to the kinds of pressures that the LV is, it just dilates. And then as the pressure overload situation goes away, the RV actually comes back to normal. Even in patients that have had right ventricular infarct and who've had a significant right ventricular dilatation, you give it some time, and the right ventricle, even though it's infarcted, recovers function more often than not. So it's a very resilient chamber in that it recovers function quickly, but it has to be, again, echoes for prognosis really in these patients. I don't want to belabor it for too long. The one thing I did want to mention is related to TAPSE. In cardiology, we don't find TAPSE to be very helpful, frankly. I know there are lots of data there, depending upon what the heart rate is, what the sensitivity and specificity of TAPSE is for the diagnosis of PE, and so on and so forth. We feel that getting a proper TAPSE measurement is quite difficult, okay, because you're often not lined up. Doppler beam is not parallel to the right ventricular free wall, and that introduces all kinds of errors. We all feel that when you have a McConnell sign and the apical tethering is sort of pulling the right ventricle upward, it's just the right ventricle. TAPSE is not really reflecting right ventricular free wall function. Right ventricular free wall function is actually artificially increased in these patients. So we don't find TAPSE that useful. There are many instances in which you find a TAPSE that's 23, 24 millimeters with a massive or a submassive pulmonary embolism. So that's a word of caution. If TAPSE is not obtained properly, then I would not recommend using it. And again, it's very difficult to obtain a TAPSE properly, even in the best of circumstances. There are lots of errors there. So what we like to use is a fractional area change. Again, the sensitivity and specificity theoretically may not be that high, but what we look for is the change in the right ventricular area at baseline and at post-systole. And a value of 35% or less is considered abnormal, but typically anything above 40% is considered pretty good. So those are the numbers that we look at. The other value that people talk about is the S prime, which is sort of the same as TAPSE. So it's, again, a tissue Doppler phenomenon, which is not readily used in the emergency room setting, so I'm not going to talk too much about that. There was a question in the chat box about right ventricular dilatation and the D-shaped septum and what the value of that is. We typically see that in patients that have chronic right ventricular overload, but it can be seen in patients in acute PE. So by itself, it's really difficult to assess. It doesn't really add too much. We know that the right ventricle is bad. That's all you can say. And it can occur in the acute phase and the chronic phase as well. The one place where you would find a little bit more, of a tie break is in patients that have right ventricular hypertrophy. And you can tell that by looking at the trabeculations in the right ventricle. If they're in the moderate or band thickness, if all of that looks really prominent, and the wall thickness, which is typically measured in the subcostal view, is more than 7 millimeters, then you think about right ventricular hypertrophy being present, and that's more of a chronic process. But apart from that, just the D-shaped septum by itself is not a useful indicator of acute versus chronic right ventricular dysfunction and overload. I hope that answered it.
Great. Well, thank you for for this time. I guess just to wrap things up a little bit here, we talked about a lot. Very helpful, kind of filling in, kind of explaining how this all works. Ashish, thank you for that. So talk about right heart pressure, right heart strain in PE, kind of what's causing it, the different echo parameters, and the 60-60 sign that we can use. And I think based on the test characteristics of this thing, it certainly is going to be enough that if you scan a patient, you see this, and the clinical situation fits, you just go get that CTPE and make the final diagnosis there. I think maybe one more question for you, Ashish. We can kind of squeak this one out, and then we'll kind of wrap up officially. So I remember I had a patient, several months ago. I mean, it was probably longer than that now, but the presumption was that the patient had a PE, right? But due to many factors that could not be overcome, we couldn't get the definitive imaging, right? And so the best I could do is some form of an echo. Assuming this is what we saw and the patient is crumping in front of us, right? They're just circling the drain and just not doing well. Do you think, based on your experience, that if we saw something that fit this mold, right? They fit the 60-60 sign, they're hemodynamically crashing, would that be enough for you to pull the trigger and say, okay, I either need to give TPA or call my interventionalist to give IA or do a thrombectomy?
Sorry. So
no
I'm sorry. No, I was on mute. I was trying to talk. No, I would agree. I think that's what I would do. I mean, I would actually thrombolize but obviously you may have a little bit of time to speak with the family, right? You may want to bring them into the conversation of the patient themselves and say, hey, this is a huge risk, but this is what we're going to do. It could potentially save your life. It can also make you bleed to death. It's possible, but this is the risk of dying without it. This is the risk of dying with it. And here we are. I think in the absence of any other good explanation, I think PE is what comes to mind. So yeah, I would agree with that.
Great. Well, that being said, I mean, I don't think we can clinically apply that anymore. So thank you again for your time, Ashish, and for your expertise. It's always a pleasure to have you on this forum. I'm sure we'll have you back at some point in time in the future. But we benefit from your input to this. For those of you guys who joined us, thank you for being here. I know it's been a good hour talking about the use of echo for PE. We talked about a lot of other things, at least mentioned them throughout the course of this talk. Other ways of assessing the heart with echo for PE, with TAPSing, with S prime and stuff like that. If you want to know more, I mean, we can certainly hit that up on this forum. But the article that I mentioned at the very beginning, this article right here, goes through all of that. And so I would highly recommend that you pull that article. Again, we'll make the link available. To you guys, and when this gets posted online, we'll make the link available there. It's just a great resource to talk about, using ultrasound for PEs. So with that being said, thanks for your time. Thanks for joining us. Go out and scan, and hopefully you guys start picking this up and start seeing patients with PE. So we'll see you next time.